Hi there, it's Dr. Fee. It's my honor and privilege to speak at the ALS Symposium. I'm recording this in 2021. I'm not sure when you are viewing it, but again, it's my pleasure to talk with you about basically an overview of ALS itself. First of all, I want to start off with disclaimers. One of them is I did do a advisory board for Biogen on an ALS drug, Topherson. I will talk about that in the lecture. The honorarium that I got was used for team building activities for the clinic staff. I have no other relationships with other pharmaceutical agents besides being the site principal investigator for many ALS clinical trials. The other disclaimer is that my spouse does not have any other financial or other relationships. Overall, the goals of this lecture, one of the big ones is I want you to understand why it takes a year on average to make the diagnosis of ALS. It is one of the biggest frustrations that our patients face early on. You know, they know they're having problems. They know that they are getting weak. And it takes longer than what one would hope or want or expect to make the diagnosis. And I'll explain why that is. The other thing that I want to go over is to talk about how we treat ALS. And one part of it is going to be medications, both for the disease itself, but also for treating symptoms. And then I also want to go over our multidisciplinary clinic. So I'm going to start off talking about what is ALS. ALS is what we call a neurodegenerative condition. And what we mean by that is it's a condition in which nerve cells, what we call neurons, die. There are many neurodegenerative conditions. The other ones you're going to know are Parkinson's disease, Alzheimer's disease. These are all conditions which are killing neurons, nerve cells in different areas of the brain. And they do have some different presentation. For ALS, it's death of what we call the motor neurons. And there's two main sets. One is what we call the upper motor neuron. It connects basically the brain to the spinal cord. And then the lower motor neuron connects the spinal cord out to the muscle. And so we tend to think of ALS as a weakness, as a motor problem, but we know it's more than that. You know, conservatively, at least half of patients have psychological, behavioral, cognitive changes. And especially through the efforts of ELSA, we are getting insights into the cause of the neuronal death. Sporadic, basically what that means is we don't know why. It's still around 85%, but genetic etiologies are around 15%. So this is a complicated slide, but it's basically how I describe to you in clinic how we move. Many of you will have heard me say that the cartoon version of how the brain moves the body is there's many different areas of the brain involved with movement. And that's this image here on the left side. Basically, there's different parts of the brain that receive information. And there's two different tracks. You may not see that on the image. And basically with that, it develops a plan of how to move. This lecture is not designed to go over that planning phase. It is incredibly complicated, but it's a planning mechanism. How the brain then sends those signals to the muscle is what's involved with ALS, and that's on the right side, this diagram. And basically it's by those motor neurons, is that once the plan is developed, it sends signals via these upper motor neurons from the brain down through the spinal cord, and they connect with the lower motor neurons in the spinal cord and go out to the muscle. And so another way of thinking about ALS is it's a motor outflow problem. Now, what is the name? Amyotrophic reflects death of the lower motor neurons with resultant muscle atrophy due to the deinnervation. And Here on the right, the smaller picture is what a healthy muscle looks like. Here on the left is what a muscle of ALS looks like, probably in a more advanced state. Basically, these muscle fibers here are very small, what we call atrophic, and they're atrophic not because the muscle itself is being directly attacked, but it's because the nerves supplying the muscles are dead. Typically, there's some resultant hypertrophy of muscle fibers to try to maintain some strength. Also, surviving muscle fibers can sprout or branch out and reinnervate the muscle, but there's a limit to how much that can be done. And that does explain some of the more rapid progression at times that can occur, is that we reach a limitation of what the surviving axons are able to recover. What does the lateral sclerosis mean? It basically reflects the findings that occur in the spinal cord. Here on the right, the smaller picture is what a healthy spinal cord looks at, fairly matched up with what's here. It's off by a level or so. And by the stain that occurs, these blue is basically the pathways that are running in the spinal cord. The actual nerve cells in the spinal cord are in this kind of H-shaped area here. And if you notice at this slide here, this is what spinal cord in ALS looks like. And this area here on the side, the lateral part where those upper motor neurons run, is very pale. It's lost those upper motor neurons. This area here on the dorsum is a sensory only set of tracks, and that's preserved because sensation is preserved in ALS. And I did something to my screen. Sorry about that. So, as I said, with one of my goals of this talk, why does it take a year from first symptom onset to make the diagnosis? To make the diagnosis, we want to see a pattern of upper and lower motor neuron involvement in multiple regions of the body, with no other etiology found to explain the findings. And what happens in ALS, and you all know this, is that it starts in one area. And when it starts in the one area, it frequently mimics more common diseases. If it's involving the hand, it's going to look like carpal tunnel syndrome. It's going to look like an ulnar neuropathy. It's going to look like a nerve root problem either in the arm or in the leg. So it frequently mimics a much more common problem. It's just, if you have surgery for carpal tunnel, if it's not carpal tunnel, there's not going to be much improvement. And basically, it takes time for the damage that occurs in ALS to spread to involve other areas. And so the pattern of presentation no longer is what we would expect for carpal tunnel syndrome. We now start thinking of other problems that could be causing it, and that's when we start thinking of ALS. And again, as I put in there in large font and with a couple of exclamation points, early on, there is not a complete or suggestive pattern. It takes time for the pattern that we want, that gets us suspicious for ALS, to develop. And what is our diagnostic criteria for ALS? It's called the Ellis-Gorria criteria. That's the town in Spain where there was an international ALS meeting on what is the diagnostic criteria for ALS. And as I put up there, it's definite, which is upper and lower motor neuron involvement in 3 regions of the body, with the regions being head, body, arms, and legs. Probable is 2 regions. There is probable with lab support, which basically by EMG testing, you see involvement in other extremities, other areas of the body. And possible is basically 1 region involved. Or you can have lower motor neuron only in certain areas or upper motor neuron only in certain areas. Truthfully, most of our patients, when they come to our new patient clinic, are probably in the probable ALS with lab support. Some of them are still possible. Some of them are more in the probable ALS. but it's not very many that are in the definite ALS diagnosis category when they first present to our clinic. Again, it takes time for the damage to spread and evolve. And most of our patients that we are seeing early in the course are probable. What is the incidence? Basically around 2 per 100,000. And it's a disease of middle to early elderly age. Peak is 60 to 70, but median is 55. The genetic cases are similar, which is a little bit different compared to other neurodegenerative conditions. Many of those have like genetic onset Parkinson's disease is usually like 20 years earlier than sporadic Parkinson's disease. Prevalence is around 5 per 100,000, and that reflects that there is early death with ALS. And usually death is occurring in 3 to 5 years after the diagnosis. One of the things that I emphasize in clinic a lot is that around 5 to 10% of patients are alive in 10 years' time without a tracheostomy, without the hole in the neck, without the ventilator breathing for them. Also, we are incorrect around 5% of the time. And usually that's early on in the course when someone fits with possible. And there are a number of you who have heard me say, I can't definitively diagnose ALS right now, but ALS is what best fits your presentation at this time. And that's, what a lot of times that's how we're approaching, the disease early on, is that it best fits with ALS, and we need time to see if it will evolve into that definitive criteria that I went over earlier. I'm not going to spend too much time on the pathophysiology. When there is damage to these motor neurons, the brain and the spinal cord itself reacts to that. That's what's called reactive astrocytosis. The astrocytes are the main support cell within the brain and the spinal cord. Microglia are also a support cell, but they activate as well. And there is also a secondary immune response. And that secondary immune response is actually a site of a lot of upcoming potential treatments for ALS. The thought being is if you inhibit or modify some secondary damaging process, you will lessen the course of the disease. Within the motor neurons, within the nerve cells that are being damaged, basically this disease is a problem of protein that can't be digested. And I'm not going to get too much into it, but basically 97% of ALS, essentially all the sporadic and a lot of the genetic forms, have an abnormal accumulation of this protein called TDP43. Some of the other genetic forms of ALS will have a different protein that's accumulating in the neurons. The genetic form C9orf72 has an additional protein that can accumulate, as well as some changes within the nucleus itself. But basically, we are born with all of the nerve cells we will have for the rest of our life. And the current thought, or the current hypothesis, if you will, is something happens that causes non-digestible proteins to accumulate in these nerve cells. And eventually they will accumulate enough, basically enough garbage will accumulate, that the cell then dies. What triggers that outside of the genetic forms, we don't know. And a lot of what I am showing on this slide is the benefit of the Ice Bucket Challenge money. So we are gaining a lot of information, and how things work in science is within basically 10 to 20 years of making a basic science discovery, we begin to have treatments being tested. And so we are beginning to get close to that treatment aspect. We're not quite there yet for everything, but we are beginning to get some. And I'll talk about one of the treatments that is coming out for SOD1. And that's just the site for the slide in the figure legend. I'm going to go over how we treat ALS. Our main treatment is treating symptoms. We do have a couple of FDA approved treatments for the disease itself, but our main treatment is symptom treatment. And obviously, all of us want to change that. When we think about ALS, we think about it as progressive weakness. We think of it as weakness in arms, weakness in legs, weakness with speaking and swallowing, weakness with breathing. And there are a bunch of other symptoms that can occur. I touched upon this earlier. 10 to 25% of people with ALS have severe depression. There's pseudobulbar affect, for which we have a very good medicine for that called Nudexta. Muscle cramping is quite common. Nutrition is a huge variable. Severe nutritional problems, malnutrition, is an independent prognostic factor. But weight loss in and of itself is associated with a decrease in quality of life. Many of you have heard me talk about this, but the feeding tube, the PEG tube, improves quality of life. But when we studied it in ALS, it's unlikely that it's providing any survival benefit. Some people will argue maybe a month's survival benefit, but it's really helps with the quality of life aspect, both in terms of stabilizing weight, but proper hydration and actually decreasing the time it takes to get the nutrition that you need. And as many of you know, that we do want your breathing to be at a certain level. The FVC means forced vital capacity. It's one of the measures on the pulmonary function testing we do in clinic. And we want that to be 15% of predicted or better for placing the PEG tube. Again, other symptoms that we address is drooling. We want to improve communication as much as possible. The other big symptom that we address is breathing. We have non-invasive means to help out with breathing. And what do we mean by that? Is that these are basically the mask-based ways of breathing. If you know someone with sleep apnea, it's basically the same setup. The invasive breathing is putting the hole in the neck, what we call the tracheostomy. Most of the time when that occurs, it's also attaching a ventilator to that, not always. Non-invasive breathing definitely improves quality of life. And it probably provides a 3-month survival benefit. And some studies have gone up to maybe an 11-month survival benefit. But if you read those studies, they really don't split out what is the benefit of a multidisciplinary clinic. And I'll talk about that in the next upcoming slides, which is this slide. The multidisciplinary clinic, it provides a 6 to 8 month survival benefit. That's retrospective data. And it has a tremendous quality of life benefit. If you remember, I said we approach ALS as weakness in arms, weakness in legs, weakness with speaking and swallowing, weakness with breathing. We have therapists for those regions. We have physical therapy, occupational therapy to help assess workaround solutions, means to minimize problems with using arms and legs. We have speech therapy and dietitian to help with speaking, swallowing issues. We have respiratory therapy to help assess breathing. Certainly we're sending a lot of our patients to pulmonary to actually get the assisted breathing, sending people to GI for assessment of PEG tubes. We are utilizing a lot of other services, but we have therapists in clinic to absolutely help with these issues as well. Also within our clinics, we have ELSA representatives, we have social work, child life, psych, chaplain services. And a shout out to Stacy and Doris. Basically, it's the ALS nurse leader who runs the clinic, and they're the ones in charge. And the multidisciplinary clinic at this point in time is the best treatment that we have for ALS, both in terms of quality of life and survival. And so it is a very important part of a person's care and treatment. I'm now going to shift gears a little bit and talk about the actual drugs that are available. The first one is Riluzole. Its other name is Rilutech. It was approved 25 years ago. And as I put on the slide towards the bottom, there's been a number of studies all showing the same thing, which is on average, there is a 3-month benefit, whether it's death, breathing metrics, whatever, there seems to be a 3-month benefit. There are some studies that are suggesting more of a 6-month, some say 12 months, but some people are saying, well, maybe Riluzole is beneficial, delays things for 6 months. But these studies have a bit of a selection bias to them. The other approved medicine is Indaravone. Its other name is Radicava. It is the medicine that's given IV in 2-week cycles, as I have up there. There's only been so far 2 published studies of Indaravone in ALS. The first phase 3 trials, there's phase 1 and phase 2 trials, but the first phase 3 trial assessed mild and moderate ALS, and it did not show a benefit. As you can see here, the group that got the Indaravone had a little bit less of a decline in the ALS FRS at roughly the 6-month time frame than the control group did, but it didn't reach statistical significance. One of the things that they had in their study when they looked at it is they had basically a quarter of their patients only had a 1 point or less change in their ALS over the study period. And so they did feel that the reason why they didn't have statistical significance is a quarter of the patients essentially didn't change over the study period. And that did seem to correlate with the milder group being the one that they would want to study for the second study. So they did a second study, second phase 3 trial. And again, it was more of the milder patients with ALS. And again, they were assessing the ALS FRS, our functional rating scale, at roughly the 6-month mark. And the group that got Indaravone now had what is a statistically significant less decline in the control group, basically around 2 points less on the ALS FRS over 6 months. And I'll talk about this in the next slide, but one of the issues with this study is they did not carry that out and say, okay, is it going to delay death by how long? Is it going to delay needing a cane by how long? Is it going to delay needing certain respiratory interventions by how long? I left this up on the screen just to remind everyone that ALS patients have a lot of problems. And these numbers here of 84% of patients in this study having adverse events, and this is between the control group and the experimental group. This is the reality of having ALS, even if you are a group that has mild disease. And one of the benefits of the multidisciplinary clinic is that we are able to help address some of these. We're not going to be able to address all of them, but we're able to address problems as they crop up. And we know there's going to be essentially constant problems over time. So getting back to what I just went over for the Indaravone group, to get a group that was going to have progression within the study time frame, it was those with mild disease and certain other inclusion criteria. And so one of the criticism is, is the medicine only for a select subset? That criteria is done for basically every study that's out there. To do a study, we have to have certain metrics. We have to have inclusion and exclusion criteria. So that criticism is for every trial that's out there. And it's why when I talked about the riluzole and talked about the number of studies that it's had, is that, ideally what we like to be able to do is reproduce those results in different studies over time to confirm that it's a valid result. And the other criticism is what I already went over, which is, what does the change in the ALS functional rating score truthfully correlate to in terms of, is it going to, prolong survival? Is it going to delay needing a cane? Those sorts of things. There are a couple of studies with oral edaravone. One of them just completed, and this data is anticipated to be released sometime in December 2021. And I recorded this on December 4th, so that has not been made public yet. We were one of the sites that participated in that study. And a lot of us are very interested in this because one of the criticisms of the edaravone is its infusion time. It's a fairly significant time ask, if you will, to get an infusion basically every day for 2 weeks, then take 2 weeks off, then get it 10 out of 14 days for 2 weeks, then take 2 weeks off. And if the oral form of edaravone works, then that's a whole different assessment of what's the benefit versus cost, if you will, of doing the treatment. Those are the only two FDA-approved medicines at this point in time. I'm going to go over a couple of medicines, a couple of treatments. This one here, AMX0035, has made a big splash in the ALS world. It's the Centaur Trial. It's a phase 2 trial looking at 2 agents, both of whom have been shown to decrease neuronal death by decreasing stress within the cell. And sorry. There's been 2 published papers on this study. One was the New England Journal article about a year ago. One of them was in Muscle and Nerve. And basically, it showed a lot of benefit, and I'll get to that benefit in just a second. I left this slide up here because this is how they screen, how they randomize, how the trial is done. And really, the point of this slide is to show that there is a lot of dropout when we do ALS clinical trials, and it makes sense because this disease progresses. People reach a point where it becomes too difficult to participate in the studies. And this dropout really does affect the results. And I don't think it's, we'll put into question the results of the study, but in the control side, only 2/3 completed the study. And in the experimental side, 2/3 completed the study. And in the control side, 3/4 completed the study. And that's a very high dropout rate for a treatment trial, but that's fairly typical in ALS research. And you have to acknowledge that when you think about, okay, are the results affected by this dropout rate? So the New England Journal article reported what was the change in the ALS FRS at, again, roughly the 6-month mark. And again, it was around 2, little bit more, point less of a decline. It was basically 25% less rate of decline. That's fairly similar to the edaravone study. But they did look at survival. And the Muscle and Nerve article talked about roughly a 6.5 month survival benefit. The graph is there on the right. And, this is very powerful data, but it's in a phase 2 trial. And phase 2 trials, phase 1 trials are more for safety. Phase 2 trials are safety, also dosage. But really it's phase 3 trials where we are doing the work to say, is it really effective in treating the disease? And that created a conundrum for the FDA, is that, do you approve a drug on phase 2 data only? And there are phase 3 trials going on for this medication. And certainly I'm going to try to get that for us here. But, you know, we want to make sure that we are above all doing no harm. And that's a tough lesson to learn. The final treatment that I want to go over is the Topherson. And if you remember from my disclaimers, I did an advisory board on this. I'm actually very excited about this medicine. And basically, this is also, it's a phase 1/2 trial, again, combining safety and dosage with the SOD1 mutation, also called SOD1 mutation. The SOD1 mutation was the first genetic mutation found in ALS about 25 years ago. And since it was the first one and discovered 25 years ago, we are more advanced on its knowledge and its potential treatments than we are with the more recently discovered one. And basically, Topherson is a segment of nucleotides trying to confuse the RNA that's made to produce the SOD1 protein. Basically, it's trying to cancel the SOD1 protein from being made. And if you notice there in a parentheses, I put that we finally have a biomarker for ALS treatment, because we can now see if there's less SOD1 protein being made as a potential biomarker for disease severity, but we can also use it as a biomarker if the treatment is doing what it's supposed to. And what I put up there is its primary outcomes are what you would expect for a study that's designed for treatment safety, dosage and safety, which is primary outcome is adverse effects, certain lab and exam changes in blood and in CSF. Secondary was the SOD1 protein concentration in CSF. And exploratory outcomes were basically the ALS-FRS, the forced vital capacity. And this is a confusing slide if you're not able to actually read everything. But basically, placebo and the lowest dose of the treatment are up here. And then the other treatment concentrations are down here. And it's showing that the drug does lower SOD1 protein in the CSF. And this is my final slide. And it's unfortunately, it's a graph that is going to be very difficult to read. But basically, this is placebo and then different concentrations of the drug plotted against ALS-FRS score. There's some changes in vital capacity. There's also some strength assessments here. And certain things, if you look, it's actually potentially very powerful treatment. For like the change in ALS-FRS at this time point, there's not really any change with some of these concentrations of Topherson. And so this is a very potential powerful treatment, but really only for those patients who have SOD1 mutations. So I am done with my presentation. If you have any questions, please let us know through Angie. She will provide her contact information. If you have any questions, if you have anything that you would like us to discuss further, either as a lecture topic for an upcoming symposium or something that we can put on the ELSA website, please also let us know. If you have a question about a certain aspect of ALS, someone else will have it as well. Please don't ask me about a medication that's in a phase 1 study. Those are still very much exploratory. But if you want me to go over again how we make the diagnosis of ALS and focus on that, I will absolutely do that again. And again, thank you very much for participating in this.